So my name is Bo Bernacki. I'm the Emerging Solutions Manager at MyHin under Rick Wilkening, Jeff Livesey, and Tim Pletcher. My primary job function in the past 5 years as I've been at MyHin is to advance our quality measure information, or QMI, use case and the various scenarios we've set up. And those have been very successful, and I'm very proud of that work. We will spare you a lengthy presentation and the rainbow slide that all of you have probably seen a few times. But I'll just say that we're here today to learn about the ever-evolving space of quality measurement. So even in these 5 years I've been at MyHin, we've seen significant changes both on the CMS, ECQM side of the house with meaningful use, MIPS, CPC Plus, and now promoting interoperability programs, as well as on the NCQA and HEDIS side, with the evolving emphasis on supplemental clinical data. The measures themselves are also evolving, and I know there's probably some doctors in the house that would have some polite feedback for some of the specific measures and why they may or may not be good or bad. But we're striving toward patient health outcome-based measures as opposed to process-oriented kind of check-the-box type measures. So everything's still in flux, and that's why we've had this quality workshop for many years going, because there's so much new content to tell you about each year. So 5 years ago to the day, I was an intern at this conference, and I had the pleasure of hearing Dr. Kevin Larsen speak. And he said a bunch of really cool things about meaningful use and all kinds of other things, but one phrase he used was really stuck with me, and that is that HIE moves at the speed of trust. And I promise I remembered all the rest of your words as well. So that really stuck with me, and in the years that followed, we, and many of you in this room are part of that, started the PPQC, or Physician Payer Quality Collaborative Group. And that phrase became very apparent. So I think we spent the first several months, maybe even up to 6 months, kind of establishing trust, getting everyone in the room. We had many of Michigan's largest payers and POs at the same table in the same room talking about how to improve the flow of quality information. We had some legal things to work out. And thanks, Jeff, for all of that. And I think we had to establish that trust as the very first thing. So after all that discussion and legal workings out, we're now proud to report that we're up and running. What started as a pilot program is now kind of in production. We have processed over 80 million records, represented by over 150 files sent by 35 unique senders. And we're distributing that data to the payers, and at least one of them have used them in their official HEDIS data submissions. So we're really up and running now, and it's been an extremely successful use case and collaborative group, and I'm so proud that we've made this progress in Michigan. All right, so without further ado, I'll kind of set up Dr. Kevin Larsen. He's the Director of Continuous Improvement and Strategic Planning staff at the Centers for Medicare and Medicaid Services, CMS. He leads the CMS Lean transformation and advises on health IT policy and care transformation. He previously served for 4 years as the Medical Director of Meaningful Use at the ONC, the Office of the National Coordinator for Health IT, where he led ONC's work on quality policy, measurement and improvement, including clinical decision support and registries. Prior to working at the federal government level, he was Chief Medical Informatics Officer and Associate Medical Director at Hennepin County Medical Center in Minneapolis. He is also an Associate Professor of Medicine at the University of Minnesota. His research includes healthcare financing for people living in poverty, computer systems to support clinical decision-making, and health literacy. In Minneapolis, he was also the medical director for the Center of Urban Health, a hospital community collaboration to eliminate health disparities. So please help me welcome Dr. Kevin Larsen.
Thank you, Bo. It's always great being here. I'm going to use my computer so I can see the slides since I can't see the screen behind. So this is really a terrific group and a terrific meeting. You guys are doing great work here in Michigan. You're one of the only states that actually has a day-long meeting around quality reporting through your HIE. So not only is the work you're doing great, the interest and the collaboration is fantastic too. So I'm going to go through a few things, talk a little bit about some of our newer policies at CMS that are just coming out, and highlight a couple of programs that we do, including our Patients Over Paperwork program, which I helped to lead, and the Quality Payment Program. A few highlights there. I won't go into the gory details because you're probably sick and tired of hearing about the Quality Payment Program. And then I'll end with some work that we've recently been doing, going around the country, observing and listening to hospitals as they do electronic quality reporting and how that's informing our strategy for ECQMs in the future. So the next slide. At CMS, we're still really focused on delivery system reform, and this is working to change how we pay providers. How we deliver care, but also how we distribute information. How do we make faster, timelier information available to more people safely and securely? You've probably seen this, but our goal has been to get many, if not everybody, in our fee-for-service programs in a linked to quality or alternative payment model. And we are on track to achieving those goals of all of our fee-for-service programs having a quality component. Some of them are small in the 2 or 3% amount of your pay is at risk, but others are much bigger depending on the program and depending on your choice for how you sign up for being in an alternative payment model. The strategic goals at CMS are to empower patients and doctors to make better decisions about their health care. So these are the strategic goals of this administration, which to my mind ring true across the work of CMS. This doesn't feel very specific to this administration. They're terrific goals, but luckily for us, there's a lot of constancy of purpose with these goals and with CMS. So we're focused on empowering patients and doctors to make better decisions of their health care, ushering in a new era of state flexibility and local leadership, supporting innovative approaches to improve quality and accessibility and affordability, and to improve the CMS customer experience. It's been fun to actually be working under some of these because the renewed focus on customer experience and the therapeutic relationship between patients and doctors has been near and dear to my heart for a long time. And so that's allowed for a lot of the work and improvement, the work in these projects to really gain prominence within the agency. So let me tell you a little bit about the Patients Over Paperwork initiative. Have any of you heard of this? So this is a top priority of this administrator, and the goal is to figure out how we put patients first. And here we're looking at reducing unnecessary burden, increasing efficiencies, and improving the outcome of the beneficiary experience. We're doing this through a couple of different methods. One has been to have open requests through our rules last year to ask people to tell us where there were burdens in the rules. So typically when we put out a proposed rule in NPRM, the feedback we get is very specific to the policies we propose. That's the way that they work. Last year and now this year, we've done something new, which is to have an RFP or an RFI, a request for information, within our rules that are wide open. Hey, tell us what's burdensome. So on all of our rules last year around our payment programs, we said, hey, tell us what burdens you have as providers or as patients, and we took those in and have been working over the last year to analyze them, sort them, score them, and then figure out how we resolve them. Some of the burdens that we heard about we can use to impact policy, But some of the burdens that we hear about actually are not about policy, they're about how we execute that policy. So we heard from our nursing home burdens that the way our surveyors go out is inconsistent, and that two different people that survey a nursing home might give two different findings on the exact same thing that they see. So that's not something we change with policy, that's something we change with operations and guidance and how we execute our work. So let me give a few examples of what we've actually heard. Oh, and the other method that we're using is human-centered design. How many of you have heard of human-centered design? So human-centered design is the approach that a lot of the companies, commercial companies that you work with, use to develop new products and services. So Disney is great at human-centered design, and Apple is great at human-centered design. The idea of human-centered design is, first and foremost, you need to understand your customers and the people interacting with your system, and you build your tools and systems around that understanding. And how do you get that understanding is a combination of data, observation, and stories. So through human-centered design, we're very committed to deep, long, personal interviews with people rather than in creating surveys where we predetermine the results. So we go into the homes of beneficiaries, we go into hospitals, we go into physician practices, we spend sometimes at a hospital, we'll spend 3 days at the hospital observing the various parts of the hospital's work. We'll go into a nursing home and do something similar, and we'll actually go into a patient's home and have a 2-hour interview with the patient about what they've heard and what they've seen. We bring all that back in and we compile that, much like we've done with the work of the open response to questions, and hear what the issues are. We've just completed our first set of that around nursing homes, and again, we had asked through our rules, tell us about what you saw, and then we went out and observed and listened, and we found 70 more individual burdens that we can address by doing this other method, by actually being in the field and listening in the field. We also hear a lot more about the sub-regulatory things that we can change and fix. So we're very excited about this method, and we're very excited about the kind of information we're learning. So some examples of the work that we've done under the Patients Over Paperwork has been to reduce the number of electronic health record measures and thresholds. We heard loud and clear through a lot of our listening sessions with physicians and through our open RFP that there was too heavy a reporting burden and too much paperwork involved in the details of tracking the meaningful use measures, especially as there are no incentive payments really for them anymore. And so that was some of the input that helped us focus on interoperability. We also have changed our guidance on medical student documentation for anyone that practices in a teaching environment where there are medical students. CMS for 20 plus years has said that medical student documentation, there are only small parts of it that can actually count for a Medicare bill, and that the physician that is overseeing that medical student has to re-document all of that fresh. This has just been changed through sub-regulatory guidance, where we said, no, medical student documentation just needs to be co-signed by attending physician, and it counts as much as an attending physician. Again, this has come through this kind of input. We want small input and big input. What do I mean by small input? Well, we heard from people that make custom orthotics for shoes, that our rules were interpreted that you could only get paid if you used a clay mold to make an orthotic. And they now have 3D imaging technology that they can just take a 3D image of your foot, and they weren't getting paid. So we said that seems silly, and again, that's all sub-regulatory. As soon as we know about that, we can change that, and we did. And we want to hear and know about a lot of those things so we can fix the little details as well as focusing on the big policy issues. As part of this, we're also focusing this patients over paperwork. We're not just focusing on the clinician, we're also focusing on the Medicare beneficiary. How is it that we are empowering beneficiaries, what it is that we can do to help beneficiaries. So there's a renewed priority around getting access to patients, to Medicare beneficiaries of their own data through Medicare. And we're very interested in hearing how we can help promote that through our policies and programs. How is it we can free up patients' access to data, not just that we can control directly because we store it, but how about the healthcare providers throughout the country? How do we help promote their sharing and easy use of that data with patients and consumers? So a little bit, if you want, these slides will be available. If we have a Patients Over Paperwork newsletter that comes out about monthly, which details some of the programs and the work and the activities. You can sign up for that newsletter here. And we also have an email box that if you have issues or items, like I mentioned with these shoe orthotics, and you want to let us know, email this email, reducingproviderburden@cms.hhs.gov. And we want to hear, we want to know, we want to be able to take that in and work to fix those issues. A little bit more about putting data in the hands of patients. So, sorry, I'm forwarding my own slides and not the ones for you. Here's the newsletter. You're not going to copy this anyway. This will be available to you. But if you just Google Patients Over Paperwork, you'll get the URL. And then here's the mailbox for reducing provider burden at CMS. So if you're interested in this, again, the slides will be available, but this is the email box that is manned and or womaned by people at CMS paying attention and helping us bring this into our system of change. So how are we going to go about putting data in the hands of patients? First of all, we're working on the Blue Button 2.0. And for Blue Button 2.0, we're doing that through an API. The first Blue Button, there was an ASCII file, if any of you have used Blue Button. It comes out in a fairly ugly printout that reminds me of the old kind of printouts we would get from mainframe computers when I was in college. And so it was not exactly user-friendly. The data was available, and all of it was available, but you really needed somebody else typically for you to be able to make a lot of sense of it and to have it be very useful. So we've now built an API, and that API is designed for other apps, other things to connect to. So apps on your iPhone, apps in your computer, apps in your personal health record can connect to this API, and with the right kind of security and permission, download your data once or on a regular routine basis. You'll notice that in the new version of Meaningful Use, there's although we've eliminated a lot of the reporting, there's still a strong focus on the consumer access to their data and on the interoperability of that data. So we've worked to make sure that remains a cornerstone of that program. We're also working with information blocking. You've heard a little bit about this, so again, I won't get too much into that so we can get further on to the quality measure and reporting. So Blue Button 2.0. For those of you not aware, this is a symbol. The blue button is almost like a brand, and that describes the way, or you can see on the screen, here's where the blue button is, where I can download my information. The hope is you'll be able to share it here too, so it may be that rather than you getting the data through Blue Button, let's say on an app, you could download your data from CMS and then have another button to press, upload it to my health plan, or upload it to my doctor, download it from my hospital, upload it to my doctor. That's the vision. I won't say that that's what's in place, but that's the IT infrastructure we're working to build to have you be in control of it and you be able to move your data around. I said this a little bit before. So our vision is a developer-friendly, standards-based API that enables beneficiaries to connect their data to applications, services, and research programs that they trust. I think the research here is important to highlight because a lot of the interest and funding for the support for this has also come from the NIH and the work through the Patient-Centered Outcomes Research Network. How do we move to personalized medicine? How do we move to you not only having control of your own data for the purposes of care delivery, but how do you have control of your own data for the purposes of research? I want to see if I might be eligible for a research project. How could I have my own data and be able to check it against a whole number of different potential studies to see if actually one of those studies is a good fit for me. So there's a lot of work going in that space too to understand how you can use your data to support research and understanding research for yourself and potentially even donate your data to research. So we are working with FHIR. I'm sure you're all, again, sick of hearing about FHIR, but it is a FHIR server, a FHIR-enabled API that we're working on, and we're using some of the Medicare claim standards is the primary thing that we're doing. I'll skip that one. And then a little bit about the IPPS rule. So how many of you here are from hospitals? A few. So often this group has a lot of predominance of people that focus on the physician measures. Our physician measure rule isn't out yet, but the hospital measure rule is out. And so I'm going to tell you a few things from the hospital measure rule, and then you can likely imagine that some of the things that come out from the hospital measure rule will likely have similar things that are going to come out in the proposed rule for physicians. So much like we did last year with the Meaningful Use Program in the hospitals, we're changing the name. We proposed changing the name to the Promoting Interoperability Program for Hospitals and no longer the EHR Incentive Program or the Meaningful Use Program. We've changed some of the scoring methodology, made it simpler, much like we did with the clinician measurement, and have changed some of the way we're thinking about CQMs. So this is designed to be aligned with the EHR Incentive Program for physicians. Because over the last year we've had a discrepancy where the physician program had a new name and a much smaller set of measures, and the hospital program was still big. It's still a lot of work, it's still a lot of stuff to do. So this is part of this patients over paperwork alignment. How do we pare this down to a more minimal set of high priority things? But still here focused on measures and objectives that are around interoperability and around patient access to data. So here are some of the measures. I won't go through these. Again, this is available to you if you want. But the objectives are down to 4 objectives. I think there used to be 12, as I remember, at once upon a time, and then we've been cutting them slowly. You'll see in here in our proposal an alignment around some of the priorities you've been hearing about here. So the E-Prescribing measures are now aligned around the opioid crisis and focusing on PDMP and using electronic prescribing for controlled substances. Again, support for referral loops. This has been around since the beginning. It's been hard for people to do. We understand that, but it's really a key and important part of assuring that patients' information follows them and ideally gets there before they do. Provider to patient exchange. So this again has been there from the beginning, but continues to be a cornerstone of being sure that patients have electronic access to their information. So these are in the proposed rule, and this is out on the street right now. If you want to go in and comment to our hospital proposed rule, the IPPS, Inpatient Prospective Payment System, here it is, and you can go and comment. So the quality payment program, this is the one that we that is for physicians, as you remember. A couple of thoughts about the quality payment program that we've heard that there are too many quality programs, that there's a lot of technology requirements for being able to enter these programs, and that measures here get between the doctor and the patient. So a lot of our work has been, again, focused on going to clinicians' offices, listening to doctors, listening and observing as they use the system. In fact, the way we build this now, we do agile development, and through our agile development, we have user-centered testing sprints. So the 2 weeks before we're going to build a feature for the quality payment program, we'd identify what very specific thing we want to learn about our user. So a few weeks ago, we were looking at how a provider enrolls in PCOS, which is the provider system for enrolling in Medicare. And so we sent an army of people out to different doctors' offices and watched them and their practice managers actually enter stuff into PCOS, gathered copious notes, and brought that back, and that became the requirements and user stories for the next set of development. And then we develop, and then we quickly test, and then we go out and figure out what the next thing is we're going to build and come back and test. And this has been a radical sea change in how we do our work, and a really important way that has made this system get a lot better feedback from our customers and a lot better usability. So these are the goals of the quality payment program: improving outcomes, reducing burden. I'm sure you've heard many of these things, so again, I won't belabor this too much. So where are we now with QPP? So there's now a single site to submit all your data. If you've logged on our QPP website, you've seen how different it is than our other websites. We really encourage you, if you haven't, go look at it, even if you're not the kind of person that's going to be entering data. Again, through this user testing and human-centered design, we've really come up with a very different way to think about interacting with government and government programs and government systems that feels more like something you'd encounter in the commercial sector. There are on-screen notifications and warnings. There are drag-and-drop file upload. You can submit data as often as you'd like. So the idea is you can submit and see how you're doing and test and retest what your data looks like. So people have really found this valuable for their quality measurement submission, because then they can double check, oh, how am I doing? What's my score going to be like? Is this going to be good? Is this not going to be good? Or is this measure going to work? That's been a high value feature for a lot of people that have used it. We also have real-time performance category scoring with a new claims to quality feature, and ways that you can, in real time, actually get feedback on where you are based on your data and based on the data that we have. The data submission ended on March 31st of 2018 for last year, but we're this ongoing development and ongoing openness and use of the system. So you can go in and be checking all year if you want on how your data looks and how your data works. And you can automate that through your electronic health record vendor or someone else. They can be looking and checking on your behalf. So what's next? We're looking at 2018 to do eligibility lookups for the merit-based incentive payment system. We're going to work to do predictive participant status. So for advanced APMs, it's been tricky for you to be able to tell, are you in it? Oh, sorry, thank you, Bo. It's been tricky for you to remember or tell if you're actually eligible to be in an advanced APM or not. And so again, through this kind of on-time, real-live checking against what we have and what we know, you'll be able to see some of those things. We're working on new looks and feel of our feedback reports. Again, this is in constant user testing, and we have a whole user testing team that tests these now in doctors' offices, with practice managers, with others. And the feedback reports will include your payment adjustment and your cost and quality score. We'll be soon in year 3 of rulemaking, and there are new flexibilities for us provided in the Bipartisan Budget Act. So we're hoping to be able to simplify some of the complex policies and scoring. I was part of the initial work to figure out how we actually build to the congressional requirements of the QPP. And I'll tell you, we spent weeks and weeks locked in conference rooms trying to figure out how to make it simple, and it was really, really hard to figure out how you make it simple with as many options and features as there are in the law. And so the fact that there was a law change that will help us make it simpler, because we were working very hard to try to do it at the beginning, and we didn't do it. It's a complicated program. A quick talk about meaningful measures. Through all of this listening and observation and feedback we've had from clinicians, they've told us that the measures are, there are too many measures and there's a lot of burden in measures. So we've launched what we call the Meaningful Measures Program, which is working to figure out how we get to an aligned set of measures with more utility and less burden. So what are we doing in the Meaningful Measures Program? We're working to remove low-value measures. If you looked at this year's IPPS rule, we actually have a new criteria that's kind of a return on investment criteria that we are doing for measures. Is the benefit of the measure greater than the cost of implementation? And we've not yet before been doing that kind of analysis, so you'll see us score and eliminate some measures out of the hospital system based on that analysis. In the past, we've only removed measures because they were topped out or the science had changed, so this is another way that we now look to remove measures. We're working to develop and implement measures that fulfill gaps in the framework, but only high-value measures. And then intensive work on health IT. How do we really help clinicians and registries and health IT organizations to reduce the burden of measurement? So the last bit, I'm going to give you some slides that very few other people have seen. Through the Centers for Clinical Standards and Quality, we've just been completing, again, a human-centered design approach to understand the burden of measurement, again, largely from the hospital side, but the measures are pretty similar in how they're constructed and what the burdens are, so I think the insights should be fairly similar. So over the winter, we had a team of people go out to 10 or 20 hospitals, and again, often spend multiple days in those hospitals observing how the hospitals reported their measures, talking to their technical teams, talking to their clinicians, and understanding what were the details of the measures and the measure submission that were problems. The scope of the project looked at the development of the measures, it looked at the reporting of the measures, and it looked at the tools of the reporting. So we were kind of top to bottom about how the measures worked and what they were. Here's the timeline. We started in October, and then we went out on site visits between December and March. We also had some interactive sessions at the CMS Quality Conference and at HIMSS, where we would have rooms like this and open feedback sessions with, again, looking to not just get policy input, but a lot of detailed input about technical problems, lack of clarity, inconsistency, et cetera. So here are some of the themes that we've heard. They probably won't be too big a shock to you, but that's okay. We've heard that there continues to be issues with alignment. Alignment across programs, and alignment sometimes of a single measure that we think is aligned, but it actually functions differently in different programs. Value, this is in part where we got this way to think about, is it worth it for us to, is the return on investment for this measure worth it? Is there actually more benefit than there is cost to implementing this measure? issues with how we communicate, issues with our certification process, which is typically done through ONC, implementation, reporting, and then measure development. So some of the high-level recommendations we have, and I'll dive into some individual slides around this, that we need to align with some strategic goals. So here are the strategic goals in the center: reducing burden, increasing value, and reducing complexity. And in the alignment space, we should work to align CQM reporting requirements and simplified program-related educational resources. What do we mean by that? Well, often each different program that has a measure has its own educational resource. And those of you that have tried to navigate the CMS education can be frustrated because there'll be a measure in the quality payment program, it's also in CPC Plus, and it's also in Physician Compare or some other place, and you have to read all three things to actually fully understand what the implications are for you. Through the quality payment program, we've been able to collapse that some, but the feedback here is we need to do that more, and we do that for more of our programs to have a streamlined way, a kind of report once way, but this isn't just about report once, it's also then about educate once. Don't tell me about it 5 times for 5 different programs. Tell me about it one time in one place for all the 5 programs that it's in. Align the set of required ECQMs across the programs where feasible for simplification and benchmarking. For example, promoting the use of the CPC Plus core set of ECQMs for primary care. So you guys know the Comprehensive Primary Care Program, that's one of our models. It's one of the largest advanced payment models we have. They have a core set of ECQMs that if you're in that model, you're required to do. Well, there are tens of thousands of providers in that model. So the goal here is to ask everyone else, hey, here's a core set we already decided is a core set for primary care through our, basically it's a patient-centered medical home advanced payment model. Let's use that as much as possible throughout all of primary care rather than as much of the kind of inconsistencies we get across multiple programs. Aligning measure specifications and data collection to improve integration into clinical workflow and ECQM implementation. This is a hard one. This is an important one. And so this is where we need that user-centered design and this adaptive model of how we build measures, much like we're doing with our websites. How do we take that same approach to building a measure where we go to multiple places, do lots of testing and multiple inputs so that we don't build a measure that locks you into a certain way of documentation or a certain workflow, but instead is flexible and lets you maintain a workflow that really works for you, but also gives you useful information, ideally in near real time, about how well you're performing. Value. So ensuring that the quality measures are valid and reliable. This is a place I spent a lot of my time at ONC. This is, again, hard. One of the reasons this is hard is because we typically don't have access to good test beds. So I built maybe 15 measures for CMS during my time at ONC, and I would call all my friends, I would wave money in their face, I would twist their arms, I would do whatever I could to try to get these measures tested in real environments. And everybody said, we are so busy with everything else, and I only have one person that understands quality measures at my hospital. There's no way, no matter how much money you can pay me, I can't test your measure. And we wanted and aspired to having lots of good testing, and we need to find ways to let that happen and let that happen routinely. So whatever creative ideas you have, we're all ears, because we want a lot of testing before we put them in our programs. But we hear over and over again from people, we're so busy we can't possibly do any more until they're in your programs and you make us do them. So breakthrough thoughts here we're very open to. We also want to be sure they're feasible and contribute to patient care. We want to encourage recognition in programs and encourage investments in ECQMs. So again, this is a reiteration that ECQMs are our future. If you look at the proposed rule for hospitals, for the first time, we have far more ECQMs than non-ECQMs in the proposed rule. As we've proposed to eliminate measures from the program, most of what we've eliminated are the non-ECQMs, and most of what we have left are ECQMs. So there's again a reiteration that this is our not the side way of doing measurement, this is the main way of doing measurement, and that we're working to use the right measurement framework for the right measurement. So there may be times that we'll still measure things in another way, if that's a better way to do measurement. But when we can and where we can, we will use ECQMs as the primary way of measurement, with the goal that they ultimately reduce the collection burden, the routine collection burden. They're likely more expensive to put in place at the beginning. But what we've been hearing from hospitals, and I don't know if it's the same with providers, what we've been hearing from hospitals is that once they've done the work to get them put in and to validate, they're actually much less costly to maintain and support than the abstraction measures. Those are really expensive. The expense never goes down. You have to hire a battalion, typically of nurses, to scrub through medical records. And if you're using that method of measurement, it never gets cheaper, because they have to always be reading through all these charts. Whereas with ECQMs, there's more cost up front, but a lot less maintenance cost through time. We've also committed to improving the communication, education, and outreach, and working on sharing best practices. In the development process, we've heard loud and clear that providers feel like measures are developed somewhere on Mars and that they don't know anything about it, and that how could possibly real-life doctors have been involved, because this doesn't make any sense. So we want to work to provide better ways to get real-life doctors and others, patients and others, involved in the development process, to make sure the measures are better fit to the practice, better fit to the medicine, better fit to the science. Working on harmonizing value sets. We had a long talk about this last night with a few people that when I was at my health system, my ECQM analyst came to me and said, why do we have 9 definitions of diabetes in 6 different measures? And that was actually true, because sometimes the exclusions for diabetes were actually defined differently than the inclusions for diabetes, and it's crazy making to everybody involved. But it's actually trickier than you'd imagine, because the people that have passion about a measure are very precise about the science, about the research, about the guideline. And that precision and passion about it means that there's compromise if you try to use the same definition of diabetes in Measure A and Measure B. Because in Measure A includes gestational diabetes, and in Measure B it doesn't. And there's good science for why that would be the case. But that doesn't mean we shouldn't do this. We absolutely should do this. It's just hard work, and we haven't yet figured out what the right solution is. We want to improve the feasibility, reliability, and validity testing. We want to communicate new measure impacts. And we really want to accelerate the ECQM development pathway. Again, we were talking about this, a few of us last night. How do we do these faster? What's a better way to develop? Right now, it takes at least $1 million and usually 5 years to build an electronic clinical quality measure. So the hypertension guidelines just changed. How long will it be before we can get that into a measure? If history is our guide, 2 to 3 years. Because people want it to be well tested. People want it to be tested in the environment. They want it to be tested to make sure it doesn't impact the workflow. All that work and testing and rebuilding and recommunication takes a lot of time and energy, and then we have to put it in a rule. So we want and need to speed that up. Here's what the development process looks like now. We want to insert this collaborative measurement development workspace into that so that we have better interaction, maybe through things like APIs or access to de-identified data sets. How do we get a crowdsource of good ideas and a crowdsource of testing, and break it into smaller chunks of build and testing like we do in Agile? Oh, here it is. We also have a recommendation about implementation and reporting process. So improving data availability and secure access to data needed that isn't natively captured in the EHR. So this is a tricky one. An example of this in the hospital is a measure called exclusive breast milk feeding. So in the nursery, there's good science that if women are exclusively breast milk feeding their babies do better, they're healthier, and they have less infections. So that's now a quality measure. But historically, nurseries weren't tracking every single time a mother fed a baby, and was it a bottle or was it breast milk? How do you incorporate that information more easily into the EHR? You know, the mom could track that on a phone app, right? That might make more sense. But that's not the EHR right now, and there aren't good pathways for that kind of stuff getting in. We want to improve timelines and releasing of ECQM annual updates. We'd love your thoughts and feedback here. Again, we've been working on this. We've been working on aligning some of this and making it more quick. But there's still work to be done. That's what we heard over and over again as we went out into the field. Adopt a pre-submission validation testing. This is, again, remember, for hospitals. We have that now for the providers. And these slides we just presented on Monday at the Joint Commission. We have an ECQM meeting at the Joint Commission every year. And the Joint Commission now has a hospital pre-testing and pre-validation tool. So any of you that want to do that kind of testing for hospital-based measures can do it through the Joint Commission's tool. We want to adopt an API for the hospital reporting, much like we've been working on for the QPP. And attribution continues to be a concern. Certification. This was the place that I owned at ONC. I owned the Health IT certification for electronic quality measures. The certification process is for your vendor, not typically for the site. And some of the challenges with certification is that the vendors needed 18 months to 2 years of advanced notice for them to be able to build their software and test it before they give it to you. So we had even more aggressive timeline than a lot of other people did, because we had to try to be 2 years ahead of what CMS was ultimately going to make their policy. So there's some inherent guesswork in that, and some amount of necessary change as defects and issues are found, which means that what we've tested and certified to as your software capabilities is sometimes not exactly what ultimately ends up in all of the details of the specifications you're required to do. So rethinking how this works, we're very interested in thoughts. Communication, education, and outreach. So again, we want to improve how we do this, and we would love your help and thoughts. How do we share best practices? How do we build ways for people to learn from others in their specialty? How do people with less infrastructure, critical access hospitals, small practices, others, get the right amount of education without it being burdensome or overly complicated? And we also heard that people want us to improve the proposed rule process. So what's happening with this? So this kind of input, we're consolidating, and again, this is all user input. We're putting together, in the process of putting together a white paper. This is, again, you're one of the very first groups to hear this, because we've just been able to kind of put it together into our findings, and then our consolidated set of findings will go through the internal government process and this white paper, and we'll determine which of the parts and features here will become our main priority areas of focus. And likely some of these findings will influence our physician fee schedule rule, as well as influence our development for both the quality payment program and our development for the hospital ECQM program, as well as ongoing thoughts about how we overall think about the life cycle of quality measures, from development to education to testing to feedback reports. So with that, I will open it up to questions. Again, it's terrific to be here. I'm happy to take questions of any and all types.
Hi, Tom Simmer from Blue Cross Blue Shield of Michigan. When I get feedback on the QPP and so forth, it's pretty good. It's about 8 out of 10. That's much higher than what Blue Cross gets for its approach to solve the same problem. And we don't just have one approach. We have 5 approaches because we have MA-PPO, MA-HMO, HMO, PPO, and Medicaid. Mm-hmm. And everyone has a different process. And so even when they're good, just the blues have already overwhelmed them. And I'm just wondering if at the level of quality reporting we could have a more common approach in our state. Michigan State Medical Society with MyHIN has a really good approach, but it's very difficult for everybody who's invested in their own things to sort of join something that would allow us to systematically address the problem from I think the root, which is not just how well it works for Medicare or Blue Cross, but how much it works in general. Any comments?
Yeah, terrific question, and I think that's the future. I think that for a number of reasons. So that we want there to be a low burden of measurement, so people's energy goes into improvement. And the more we make it complex, the more we have a lot of work to figure out how to comply with it, like a super complicated tax code, the more energy and money and time people are putting into simply trying to get the measurement right, and they don't have the resources to do what we really care about, which is improve hypertension, improve diabetes control. So, not just because it makes doctors happier, but actually hopefully because it makes it easier to get the improvement done. We aspire to the same goal that you do. The question is how to get there, right? And part of the model that I really love about what you're doing in Michigan is this collective, collaborative model. And if done right, again, for you as participants, it should let you lower your own cost, because ultimately you can just have a contribution investment rather than the full investment of a full program. So you can lower your cost by having a contribution investment. Also, what we hear is a lot of people on both sides, both the payers, where I am and where you are, and the providers would love a trusted third party to do this. There's a little bit of distrust if it's a payer to provider direct relationship, because either of us thinks the other one only has our own self-interest in mind. If we can figure out a trusted third-party intermediary, there's an opportunity that we both better trust for them to adjudicate and them to kind of set a clear set of boundaries with our participation. How to do that? There are models for it in many states that emerged out of HEDIS measurement. And in some of those states, the data actually flows through this measurement collaboratory, they're typically called in the state. So in my home state of Minnesota, there's something called Minnesota Community Measurement, which the payers, all except for Medicare, agreed would be the source of truth and the aggregator of measures, and they build scorecards across the state, and all of the contracts between payers and providers that have a quality component use what's called Minnesota Health Grades, which is based out of this Minnesota Collaboratory. That's an independent organization that does that measurement. So there are models, and there are actually national collections of these collaboratories that share best practices and share ways to do it. CMS is interested in figuring out how we're part of that too. Often we're part of it at the state level through Medicaid, but more and more through things like the CPC Plus program. So I mentioned that a little bit. It's an advanced payment model that incentivizes a patient-centered medical home, but it's an all-payer model. That's the important thing to know. So in a market, you have to get all the payers to agree to the same kind of incentives around patient-centered medical homes, part of which are quality measures, and part of it is kind of your patient care management. So there, we as Medicare have had to also be in on that collective set of setting those measures and helping set the groundwork across that model. So I agree, and I think that what you're doing here is leading the way. but would love to know how we can help and how we can contribute. One of the challenges for CMS is it's hard for us to participate in 50 different models. Can we? We can, but then usually we defer to the state. And so since Medicare is fundamentally paid for federally, it's hard for us to break that into 50 different flavors for 50 different states. So we have a little bit of a challenge in figuring out how to do that if we allow complete state adaptation. Other questions?
Dr. Larson, thank you for the presentation. It's really wonderful. The question that I have is on the ECQM strategy. When you were working, you mentioned about making sure that you were talking to different individuals and organizations. My question is, did you also take into consideration the different federal organizations like HRSA or Bureau of Primary Health Care? Because I am representing the federally qualified health centers, and for us, uniform data system is the way we report out, and those measures, they don't necessarily align with the ECQMs. So what is being done to have that dialogue between different federal organizations, and how do you align those?
It's a terrific comment. My job at the Office of National Coordinator was to coordinate across all of these programs, and so I saw the same gaps that you see. I would encourage you to tell us about that in writing through things like our open request for input on our policies. I worked a lot with the Bureau of Primary Health Care at HRSA, and they are working on updating and modernizing their measurement and data collection system. They're actually using a lot of the lessons learned of QPP to figure out how to do that. But they're going to need input from people like you about how much and where should that alignment actually be. They have some slightly different goals. For those of you that have never seen how they measure the Uniform Data System, UDS, it doesn't just measure kind of individual patient outcomes. It has some effectiveness as a clinic measures, some overall kind of population-like measures of how your care is delivered. You have to, for example, have a board that's made up of a majority of the board members have to be patients of your clinic, and you have to report that. So that's not a quality measure like we think of quality measures in the Medicare space. So they have some work to do to figure out how they would, what's the place they can align, and then what's the place they intentionally maintain the integrity of what they want to maintain for their program. But I totally hear you, and I know they're interested, and I know they're working on it, and we're happy to work and partner with them as well. I wish I had a more concrete answer to say it was all going to get better next year, but I don't.
Hi, Deb Merlino from United Physicians. Back to the EHR certification. As a PL, we get data from a whole bunch of EHRs, and I think fundamentally, they don't do basic checks on the data, like validating that it's a valid weight, that it's a valid blood pressure. I think that should be part of the certification process so that, you know, we get quality data. We're getting data, and a lot of it's meaningless and doesn't make sense.
Thank you. That's great input. The certification system actually has its own set of rules, believe it or not. So that's what the ONC rule is, the certification rule. The last one was the 2015 certification edition, which we published in 2015. And that's the kind of feedback to give us and to give to CMS. I think certification is only one part of it. So certification is one-time testing. And what we know from one-time testing is it means you can do something, but it doesn't mean that you do it, right? It just means you can. And so another question is, how do we build systems that make it easiest to do that kind of data checking and have it done routinely and reliably? So I know, for example, MyHIN does a bunch of that on the data that moves through MyHIN. And that's a way that each and every day, each and every record, you can potentially get testing on. So you're likely to pick up things that change in the middle of the year that the certification program would never actually find. Because we just tested it at one time at the beginning, and they necessarily have to make changes, security updates, whatever it is, and something will change in the middle of it, and certification testing won't catch that. So we'll love the feedback about what we can do more for this one-time certification testing, but also help us collectively think about what are the routine ways we help and support these practices to build their systems in a way that enforces accuracy, but also that does this kind of real-time data check so that they can catch their problems early rather than having to wait till they get a report and their measures were all wrong because their data was bad. Yeah, no, I agreed.
It's not a valid number.
We had a lot of talk about that at ONC about what would the parameters be for various data elements, and there are a few of them that we thought we could probably certify to, but it quickly got really challenging because you get to neonates, and you get to all these extremes of people, and what's the parameter we can set that we can say you'll never ever have to put something in there that says that, and it actually got harder than you'd imagine. What's the highest weight you can put in? Well, 1,000 pounds, 1,200 pounds. For most people that's a ridiculous error. For a couple of people that's true. So anyway, it's the legitimate questions about how we should put hard stops there or gentle reminders.
Hi, I'm Jackie Sproat from the state of Michigan, and I'm wondering if there are any efforts underway at CMS to facilitate state governments to have improved access to data from DSNP, the dual eligible special needs Medicare plans. We're finding it really challenging to do quality work and population health, knowing that we don't have access to that data.
Thank you. That's definitely the kind of thing right into us about. We've heard routinely that Medicare Advantage plans are actually harder for people to get data from, and that also the Medicaid managed care plans in many states, state governments are challenged to get access to. We are now at Medicare, 30% of Medicare beneficiaries are covered under a Medicare Advantage plan. So the more we work to allow these the plans that actually are a commercial payer that's doing work on behalf of the government, we've got to figure out how we get good data sharing and signal, and we haven't figured all that out, because part of what we want them to do is innovate, which necessarily means they're going to be different, which then means that the data cells are different and the way they do things is different, and so there's actually a little bit more work in figuring out how to bring the things together. There's also, in talking to them, sometimes some concern that they don't want to share all their special sauce, because the reason we've asked them to be a commercial in the competitive market is to do things a little differently. And if they're share everything with us, then suddenly someone else can replicate exactly what it is they do. So there's a little bit of a interesting, dynamic there, but I hear you, and absolutely, let us know that in writing. That's the perfect kind of thing to write into us about. We want to make data available. We want to make data available to you and to the consumers. And we need to know where it is you're having trouble. Others?
One more. Fayyaz Sayed with Michigan Primary Care Association. I forgot to introduce myself last time. So for some of our rural providers, for meaningful use attestation, the interoperability measure, electronic transitions of care was a barrier because some of the specialty providers were not participating in meaningful use or MIPS. And now with promoting interoperability, I was wondering what kind of implications or consequences these providers might have, the ones that are not necessarily participating in either MIPS or meaningful use.
So if you're eligible for MIPS participation and you don't participate, there is a payment reduction that you can have that can be up to 9% of your Medicare payments that you could potentially lose out on. We have heard that some providers do a cost-benefit calculation and determine that for the amount of money they're getting from Medicare to get a 9% reduction it's actually worth it rather than the investment in the systems and the processes they would have to put in place in order to be able to comply. So beyond that, beyond what's in the rule and beyond what's in the program, there is no additional penalty other than what you see in the rule. We did last year also raise the amount of Medicare work that you have to do in order to qualify. So less providers actually are mandated to be eligible into the program this year than were the year before, because we raised the eligibility volume of Medicare you needed.
Under information blocking, will there be consequences? That's my question.
So that's another question. We don't really have an information blocking penalty yet. Right now, we're mandated to report about information blocking. And the information blocking has primarily focused on large organizations, including large electronic health record vendors, potentially health systems and others that would block information. That's where most of the energy and most of what Congress is talking about. So they would be more concerned if you reported one of the big EHR vendors that supports a lot of those practices is systematically blocking the information, rather than, in this small rural community, these 5 specialists have decided not to share data. That we may eventually get there, but I think people feel like there are starting with the big systems and the big owners of data is the most important place to get started, and figuring out when the information blocking is with intent versus when there's some technical reason or some cost reason that's been the main reason not to share. Others? Bo?
I can probably speak up. So, regarding the formats for transporting data, just to take it down one level for one question is, we had QRDA promoted with meaningful use, and then MIPS came along, and a Control F of QRDA yielded very few results in that whole legislation, and it did not mandate submission of QRDAs on the provider side. So I was speaking with Bryn Rhodes, who's an HL7 fire expert, and fire was kind of designed to operate on the same kind of model of QRDA. So do you see fire as kind of the next evolution kind of out of QRDA, and do you think that fire might eventually be legislatively mandated to be adopted to spur adoption?
Yeah, so we've been working on fire specification for quality measures for at least 3 years and maybe longer. So we've seen the writing on the wall and know that we want to move to a more API-based way to do this rather than just doing it all in an XML markup way. So QRDA is an XML format and fire is an API format, is at least my basic way to describe it to people that aren't in the weeds of the details. And yes, absolutely, we want to move. You saw that we're committed still to using standards and using a standards-based way to do this. We've heard from providers and from the industry, don't change the standards too fast. Make sure the standards are tested and ready to use. And don't make us just suddenly switch to a new standard next year because it's the hot new thing. So what we're trying to figure out, and I don't know that we've always done it right, but we're trying to figure out what's the pace of change to get to more modern, better tested standards. We definitely believe FHIR is the future, and there are already people testing, and I think you guys are part of it, testing the FHIR CQM standards. But you heard from the feedback we heard from the field, make sure this works, make sure it's tested, make sure my vendor can do it, make sure everybody else can do it before you make me do it. What I would guess, and this is just a guess, is we'll likely have some period of time with multiple standards allowable, both QRDA and FHIR as a kind of transition path, and then ultimately through time transition over to FHIR. But I don't have a crystal ball to tell you what the dates of that transition path will be. It makes sense to keep an eye on what the hospitals are doing because they are a much more consolidated market with more capital. So there are only about 4,000 hospitals in the country. They only really have to report to the Joint Commission and to CMS. They don't even report to the states. So it's a much simpler market with a lot more capital, so they tend to be able to innovate and move faster than the really diverse market of physicians who report to Medicaid and to multiple health plans and to Medicare and to multiple places, and they just, they're smaller. So I would keep an eye on the hospital reporting program and see what it is they do and how they do it, because we can be a little more nimble there than we can in the providers. Thank you. This is terrific. I look forward to the rest of the day. It's always fun to come here to Michigan and see the great work. And again, you're one of the few places that spends so much brain power on electronic quality measures as a state. So kudos to you and keep up the good work.